Texas. So let's welcome Dr. Krigsman.
Thank you very much, Dr. Fry. Dr. Antonucci, thank you for your lecture as well. And Dr. Antonucci is very unique. I want everyone to realize this, that for many years, autism was first described as a psychiatric disorder in the 1940s by Dr. Leo Kanner. And for at least 50 years after that, it was kept in the domain of psychiatrists and psychologists. And they had some very strange ideas about autism and what causes it and what to do for it. Really strange ideas. I mean, I remember when I first started practicing, seeing these kids 20 years ago, there's one woman from France who told me that the French psychologists diagnosed, this is now in 2001, this is not 1950. The French psychologist who saw her said, he was a bit of an older gentleman, he said that the problem with the child is because she's not raising him properly. It's the refrigerator mother theory that goes back 80 years. And I was actually hearing it from a person who was told this, and they wanted to take the child away from her and put this kid in an institution. So, but because of that, and it took in the late 1990s, I would say, is when it first began, the idea that that autism may have some real medical comorbidities, medical associations, perhaps even medical causes. And the world of psychiatry and psychology has been very, very slow to accept that idea. So when we have someone like Dr. Antonucci who comes from the world of psychiatry and explains his findings, we have to realize that that represents a monumental shift in thinking. And still, one of the major problems that we have today is that when you have a diagnosis made of autism, it's made by a psychologist or a psychiatrist, and very often what the parents are first told by that first person who they see, that's very often what they stick with. And if that psychiatrist or psychologist is a person that believes that this is a psychiatric disorder, then that's often where this child will stay, and they won't benefit from many of the treatments you're going to be hearing about. I particularly enjoyed your slide about the multi-headed snake, and that's really how we think of it as well. One of the heads of the snake is the gastrointestinal head. Now, so far, even after just one lecture, probably your heads are spinning with all that information. There's this problem and that problem, and we do this, and there's a B12 issue and a methylation issue and a calcium issue and an anti-neuronal antibody issue, and then there are so many different things. Where do you start? I'm here to add just one more thing, and that's the gastrointestinal component. And we're going to try and go. It's a lot of material. It's like 20 years of my experience in publications, kind of condensed into 30 minutes. So it might be a bit fast for some of you. It might be too slow for some of you. But certainly, I'm available for questions afterwards. Okay, so my interest has been the diagnosis of autism-associated enterocolitis, so that, as was mentioned before, when you look at well-done prospective papers that try and determine the frequency of GI symptoms in children with autism, the number is about 70 to 80%. When you look at the older original studies in 2003 and 2005, which were based on chart reviews and everything. The numbers were much smaller, but well-done prospective studies, and then finally a meta-analysis that was done in 2014 showed that it really is much more common in ASD, that gastrointestinal symptoms is much more common in ASD than in healthy children without ASD. Now, symptoms, right, are what you see. In other words, I'm sorry, a symptom is what the patient experiences. So abdominal pain is a symptom. Nausea is a symptom. Vomiting is what's called a sign. Vomiting is something that that you don't rely on the patient to say, but that you can see. So vomiting, weight loss, those are all signs. So we have signs and symptoms of gastrointestinal disease, and any given child, any given autistic child can have any one of them, and ultimately the vast majority will have this bowel inflammation that we're going to speak about now. The reason why we call it ASD-associated enterocolitis, the term enterocolitis, entero is small bowel, colitis means it's the colon. ASD-associated means that it's unique to children with ASD. In other words, the specific kind of inflammation, the specific types of cells that are infiltrating, the white blood cells that are infiltrating, the specific molecular nature of that inflammation of the lining of the intestine, anywhere in the intestine, that only occurs in children who have the developmental disorder that we can label as autism. So when you have the specific deficits developmentally that you can call autism, those are the kids who have this unique form of intestinal inflammation, which is amazing because that means that the two are probably related. You don't find enterocolitis in other developmental diseases. You don't find it in Down syndrome. You don't find it in other chromosomal diseases. You don't find it in pediatric stroke victims. You don't find it in neonatal asphyxia and developmental delay from that. You only find it in children who have the unique characteristics that allow us to call them autistic. What are the symptoms? It's actually this slide should be labeled signs and symptoms. So the symptoms that we see of children with ASD enterocolitis could be diarrhea. Diarrhea could be is not just watery stool, but it's stool that I define it as stool, or it's often defined in academics as stool that is loose enough that it conforms to the container that it's put in. So if you have stool that's like creamed spinach, okay, or if you have stool that's like a loose oatmeal, right, that would be considered diarrhea. It doesn't have to be watery. They often have constipation. Constipation could be hard stool. Constipation could also be stool that's infrequent, once every 5 days, 6 days, once every 10 days. Even if the stool that finally comes out after 10 days looks normal, it's still called constipation. So they can have that. Abdominal pain. They can have failure to thrive, meaning that they're not growing at their pre-established growth percentiles. And by the way, the abdominal pain one is a tricky one because part of what we're going to be speaking about is that if you have a patient, if you have a child who's 5 years old and has autism and is nonverbal and they have pain, how do you know that? Okay, so it's one of the clinical problems that makes it difficult to study this, and we'll show you how we overcame that and how we solved that problem. I've had to define and recognize abdominal pain. Weight loss, okay, that's easy, that's a sign as opposed to a symptom. Vomiting, and this vomiting is when food comes up, you have contraction of the muscles of your abdomen, and food forcefully comes up out of your mouth, as opposed to regurgitation where there's no There's no forcing there. It just comes up by itself. And all of us have experienced all these things, and we know. But these are kids who have this happening every day or multiple times per day. Food refusal is also a GI symptom. Patients who can go on for days and not want to have anything. They'll only drink minimal amounts, and then they will eat, and then they go another week and they don't eat. Abnormal stools that have undigested food, they smell terrible, they're light yellow in color, and food intolerances, meaning not food allergies, but food intolerances where there's no measurable abnormality in the blood to the food, but when these kids will eat the food, strange things happen to them, either gastrointestinally or behaviorally. So these are all GI signs and symptoms that when I hear that, when I have my initial conversation with the parents, and I hear that any of these things, any or all or any combination of these are going on, this makes me immediately suspect in a child who can barely communicate that this is what's going on with them. And again, this is over years of having scoped kids, seen them. A lot of the kids are able, as you know, to type on a keyboard even though they can't speak. And they'll explain to me. I learned a lot from those kids. They explain to me exactly what they feel and exactly why they do things, even though they can't talk. So when you have a child who has that kind of history and symptoms, then what you do is you approach them the same way you approach any other child. You do a basic non-invasive workup. You do basic blood tests to rule out diseases like celiac diseases. You want to look at their stool to see if there are infections. It almost always is negative. So when you have these symptoms as being prominent, you do a workup looking for any other explainable cause of those symptoms, and you don't find anything. Abdominal x-rays usually show a colon that's massively filled up with stool, even in those children who have diarrhea as a symptom. So at that point, like any other 5-year-old, when you have unexplained chronic GI symptoms of this nature, the next step is to do a diagnostic endoscopy. And that's upper endoscopy. And again, over the years, I've learned that you really don't know. Normally, when children will talk to you, you can choose which type of endoscopy to do based on what they say. Like if they're only vomiting, but nothing else is wrong with them, then you know to do only an upper endoscopy. Over the years, what I've learned is that when a child has GI symptoms, I just do a full gastrointestinal survey from top to bottom, do an upper endoscopy, and do a colonoscopy from below. And what we find when we do that, let's see. Right. We find when we do that is that looking at the colon, these are examples of colitis. Normally the colon is pink, not red and blotchy. Usually there are nice blood vessels here. They are decreased. On biopsy, you see over here this influx of lymphocytes. This is a chronic colitis. Over here you see a bifurcated crypt. So those of you who are in the field of medicine or GI will recognize this biopsy immediately as a mild colitis. When I do a colonoscopy and I get into the ileum, the end of the small bowel, you see a marked degree of enlargement of the lymphoid nodules. That itself is not a disease, but that does mean that the lymphoid system, the immune system of the gastrointestinal tract, is markedly activated, and you get enlarged lymph nodes. And you get that in other diseases as well. So if you have, for example, a bad sore throat, strep throat, right? So that child's going to have those glands in their throat, and even as adults, you get a viral infection, you get those glands enlarged in your neck. Those are lymph nodes that normally are microscopic, but they become huge during an infection, or for whatever other reason the immune system perceives as foreign, something foreign, and they try and kill it. So these massively enlarged lymph nodes are an indication that the immune system is activated, although it's not the same as having inflammation itself. And there are times, though, that we have ileitis, where you have infiltrate of the crypt of the ileum, and that's an ileitis. The small bowel is usually where we see our best findings. So very often, especially in the young patients, I'll do an upper endoscopy, it's normal. I'll do a colonoscopy, it's normal. But on a capsule endoscopy, which is a pill that is either swallowed or placed with the endoscope, it takes 8 photographs per second for 8 hours. So it really gets a great view of the entire small intestine. I mean, small intestine in a 6-year-old kid can be 10 or 11 feet long. I'm not sure what that is in meters. Maybe the translator can explain if they can make that conversion, but it's long. It's long, and it's the majority of the intestine is a small bowel, and we don't see it unless we do a capsule endoscopy. And what I find are either we find typically ulcerations. We find them in the jejunum. We can find inflammation, which is circled and arrowed in an area where it's more intensely red than pink. And at the extreme, you can find an actual ulcer. This is more of what you would see in classic Crohn's disease. These are really early versions. These are early versions of what will become that. So that's what I see during the endoscopy, capsule endoscopy. And over the years, there's been numerous publications, and I can provide those interested with the bibliography of the citations afterwards. But we know from again, many years of work on this and many publications, that the clinical presentation of GI symptoms in these children is unusual. They have a unique cellular infiltrate, so that when you examine and stain for the cells that are infiltrating the mucosa, they are not like the cells that are present in Crohn's disease and ulcerative colitis or any other inflammatory bowel disease. And the molecular evidence also, the molecular evidence was a paper that we published in 2013 and again in 2016. And just very quickly, this is called the PCA analysis, for those of you familiar with it. And what it does is that it's not measuring the genes of the biopsy, but rather the gene expression. So what genes do is they produce proteins. When you take blood, you have tens of thousands of different proteins. So how do you take, and if you want to compare, take 100 kids with autism and draw blood from all of them and compare the protein content of each one to the other, it's a huge amount of data. How do you possibly do that? So this is the way that we do it in graphic presentation. With the PCA, or principal component analysis. Each one of these dots is one patient. So the dot is all of their proteins condensed into one spot on a 3-dimensional rotating graph. So this graph, actually, the software lets you rotate and you can see it. And it allows you to measure how same or how different one patient is from another. So what we found is that the patients who had Crohn's disease, who were blue, they tended to group the cluster in this area. Patients with ulcerative colitis who were green, the molecules that their genes produced tended to cluster in another area. I'm sorry, the green is kids who are normal. The green is kids who were normal, who had no GI symptoms, who had no GI disease. who was scoped only because they had some mild symptoms. The purple are the autistic kids. And the purple, what was interesting is that you see the significant, and it was statistically significant overlap between Crohn's disease and, again, of the ulcerative colitis patients. And then there was this outlying group on the side, and we analyzed each group differently, and we'll get into that in a different lecture. But the main point of this slide is to show that there's a molecular overlap, but not quite the same as Crohn's disease. There are differences. So we have a molecular uniqueness, yet there is a Crohn's disease overlap. And this is taken from the colon, which shows you the exact same type of clustering. The clustering of the green patients, the healthy kids, are all in one area. The Crohn's patients seem to cluster together in another area. The autistic kids clustered primarily with the Crohn's patients, and some of them with the non-Crohn's patients. So the immunopathologic nature of this disease has been well established. So therefore, it makes sense to treat it. In other words, how do you treat this disease? So because of the overlap with Crohn's disease that we've shown, both molecularly and cellularly, even though it's not Crohn's disease, it is different. But because there is significant overlap, then that justifies, in the absence of any other treatment and in the presence of significant symptoms, treating it like we would treat Crohn's disease. The way that I've decided to treat them is to give initially a course of steroids. Of course, steroids are a great drug for an autoimmune inflammatory condition, but of course you can't be on steroids too long, otherwise there are side effects that are really unacceptable these days where so many other drugs are available. Steroids are good because it gives the patient relief very quickly. Within a week or 2 or 3, they have very significant relief of their symptoms, and we're going to show that graphically soon in our next study. And following that, I put them on I transition them. We stop the steroids, we go to a non-steroidal anti-inflammatory, and then, as patients with Crohn's do, they go down 3 or 4 different possible pathways. Some patients are able to stay on the relatively mild anti-inflammatory drug. Some of the patients need to go on stronger drugs that are immune modulating, like methotrexate or 6-mercaptopurine. Some patients need to go on newer versions of drugs that we use for IBD and other autoimmune diseases called biologic agents, and I've had my best success with that adalimumab, otherwise known as Humira. And by the way, what I'm saying now, again, as a disclaimer, this is not to say that this is what you should do with your child, because the study that shows the efficacy, the study that shows that the medication actually works for these kids, that study, I'll show you the current data, but has not yet been published. So we can't yet make a claim, and certainly hasn't been approved yet. So we can't make that claim, but you definitely will want to know what I'm doing. So for the purposes of the lecture, I'm letting you know that this is how I approach these patients. Currently, we're doing a treatment study funded by the Brain Foundation. Logo is on all of the slides. And the goal of the study is that we want to know, number one, are the GI symptoms. First and foremost, I'm a gastroenterologist. I'm not here to treat autism. If you're giving medications for inflammatory bowel disease to this patient with these GI symptoms, do those symptoms get better? Do they gain weight? Does the vomiting go away? Do they have an increased appetite? Number one. And number two is, does their autism improve? meaning do their behaviors, to the extremes of their behaviors, the kids who are terribly hyperactive or violent or destructive or self-injurious, does that get better? And lastly, does their cognition improve? Do they think better? Do they respond to instructions? Do they seem to understand you better? Do they make better eye contact? Do they communicate? So those are cognitive. So we have three outcomes. Primarily, it's a gastrointestinal symptom outcome. Secondary outcome is behavioral outcome. And the third outcome is, does treating the GI disease help their cognition, the actual autism itself? Those are the questions that we asked. So this is a 3-year study. And okay, the next part is the study itself. And this is by my colleague, Steve Walker at Wake Forest University, also funded by the Brain Foundation. So the study itself, again, this is the question. Does it help the GI symptoms? Does it help cognition and behavior? The study design, as you can see, is that a patient comes to me, has proper GI symptoms, has an endoscopy, the biopsies, the capsule endoscopy shows the presence of enterocolitis, and now they're going to be treated. So the patients who agree, who consent, they fill out questionnaires. They fill out a GI questionnaire, and they fill out a baseline autism questionnaires. And the frequency of the questionnaires are, again, there are 2 unique gastrointestinal questionnaires that they do at baseline, and they do it weekly. So we provide them with a link, online link, and they answer specific GI questions. And then the autistic evaluations are done again at baseline, and we have 3 separate autism metrics and ways to quantify the degrees and types and domains of autism. And we do them all at baseline. We do them all at the end of 1 year. And at 3 months, 6 months, and 9 months, we do some of them. Now, what's interesting is that we had to make our own GI questionnaire, because when you read about any GI drug, when any pharmaceutical company or any manufacturers or any physicians are prescribing a drug for a disease, then they know, based upon the clinical trial, how that drug is tolerated and if you can see improvements of the symptoms. But remember, when in autism, because these children can't really communicate, then we can assess their signs. We can know if vomiting is better, we can know if the stool changes is better, but we cannot assess abdominal pain. We cannot assess nausea. We cannot assess food refusal because things make them feel sick. Those can't be assessed, but our suspicion, and probably your experience over the years, has been that those GI diseases are often manifested by behavior. So the kid who is in abdominal pain will have aggression or self-injury. So the questionnaire that we've developed doesn't ask for symptoms, the usual GI symptoms, but rather it asks questions regarding the behaviors and also cognition that are centering around the bowel movements themselves and also in general their behavior, even if it isn't bowel movement related. This is just some information about the study itself. this is only one, this is the first year. We began the study in January of 2020, right before COVID started. So we weren't able to perform a lot of the endoscopies that year. So we had 11 who finished the first year. How much time do I have left? 2 minutes, okay. So we had, this is a summation of the first year, which was 11 because of COVID. And basically we found that as far as types of stools, you can see the stooling behaviors, meaning that while they were having bowel movements, the expressions of pain all decreased significantly. This is P of 0.5, and we saw both in two types of graphical presentations. What's interesting also is that we saw it early on and we saw it throughout as well. The same is true for the stool characteristics, meaning the looseness of the stool, the odor of the stool, the undigested stool. And there, in that, it was even more significant. It was, you see those two asterisks, it was a P of 0.01. Frequency of events, meaning whatever we're looking at, whatever behavior, was it, whether it's aggression or self-injury, whether it's improved communication, all of those happened, the frequency of them, right, decreased, in other words, improved over the course of the study. The composite score was also improved. Now, what's interesting is that the composite score, according to our data, only improved over the first 12 weeks, but didn't improve afterwards. And the reason why was because of those 11 kids, one of them, right, who just didn't respond at all to anything that I did. And I've learned a lot of tricks over the years. Nothing I did helped this child's bowel movements. And I scoped him again after the year. And we did a full bowel prep to get all the stool out. And I put the scope in. And I should normally see a clean colon after that. I put the scope in and I found a piece of stool that was, I would say it was around this big. And this is a 9-year-old child. And it was just sitting there. And this thing hadn't moved. It was getting bigger and bigger and bigger over the year. And I had to break it apart manually during the endoscopy. When we took that child out, right? When we took that child out of our calculation, and now we have 10 children, all of a sudden the composite scores are very, very significant. And you see significant improvement in the entirety of their GI symptoms. And when it comes to their behaviors, we have the exact same finding. The externalizing behaviors improved markedly over the course of the year, in tandem with their improved GI symptoms. Their abdominal pain improved, their composite scores improved. Okay, and these are all the various different, these are the SRS and the Vineland, and it was the same in all of them. We saw improvement in all of those. And we can make these slides available since we're running out of time. I knew it was going to be a long lecture. And again, we just see the improvement. It was across every single domain, but it was in cognition, it was in behavior, it was in GI symptoms. And these are all data summaries of this. This is just amazing. It's amazing information. Now, the question is why? So is it that the GI disease is causing autism? Does the autism cause the GI disease? Does something upstream cause both of them? And that we don't know yet. That we don't know. And that's why I say I go back to that picture with the multi-headed animal or whatever. That this is the gastrointestinal disease is just one more piece that we know that if you address it, then you can improve the life of these children significantly. And these are the key takeaways. And you can photograph this because this is really what I want you to go home with. I want to give a thank you to the organizers of this conference. Thank you very much for doing this, for bringing this information to Serbia. And I also wanted to tell you, as the last thing, is that a lot of parents have expressed to me that they feel that here in Serbia, they're 15, 20 years behind what's happening in America. And as I think Dr. Fry would tell you, that's not really true, because in America, there are just very few people that have an interest in working on these kids. And the reasons for that, it's a different lecture in and of itself. So you're not behind. You're lucky, you're very fortunate to have a number of young, fiery, tough moms who are working to make things better for these kids. And that's the group that you should be looking to and speaking to, bouncing information, because you're going to learn the most from those people. Don't accept from a psychiatrist or a psychologist at the age of 4 that nothing could be done for your child. Thank you.
We have time for about 1 or 2 questions. Does anybody have a question they'd like to ask Dr. Krigsman? Okay. I think, yeah, so I think you need to.
I want to ask you, is there connection between IBD in parents and autism in child?
Yes, there is a connection between not just IBD in parents, but autoimmune disease in general. This is published in numerous publications, numerous institutions. If a child has autism, there is I don't remember the number, but it's a markedly increased chance that a first-degree relative has either Crohn's disease, ulcerative colitis. The most common one that we find is that the mother has Hashimoto's thyroiditis. That's the most common one that I found. But you can have a number of any one of a number of autoimmune diseases in the family.
I have another question. Do you see in your practice some type of diet that helps children? And if these kind of diets that Dr. Antonucci told us about, and there are many more, if they correlate with improvements in your endoscopies? Absolutely.
So dietary restriction is the very first thing that any parent should try when the child has GI symptoms. It's not because of an allergy. It's an intolerance that we don't yet understand. But now sometimes there are some patients who I hear from other physicians, like Dr. Fry, Dr. Antonucci, who they go on a gluten-free, casein-free diet, and all of their GI problems go away. All of them. So now those are the kids that I really want to see, but I can't, because they have no symptoms. But yes, that should be the very first thing that you should try.
We have a question here from online. Do you see, decreased enzymatic production is sometimes seen as autism. And is this something that you can test or see during the endoscopy or another part of your exam?
Sorry, decreased what production?
Increased production of enzymes.
Okay, so there are publications there are 3 publications I'm aware of that have looked at that to see whether there are there are 2 types of enzymes. There are enzymes that line the small intestine, the disaccharide-dase enzymes, and then there are pancreatic enzymes. So the studies that were done looking for pancreatic enzymes showed that there were no deficiencies of pancreatic enzymes. The 3 studies that looked at brush border enzymes, 2 of them showed deficiency and 1 of them showed no deficiency. So what that means is probably what I see clinically is that this is a patchy disease, and Crohn's disease also. There are areas that are normal in the intestine, and then there are areas that are not normal. So depending on where you get your biopsy from, you're going to get different results. That's my interpretation of conflicting results.
But you are able to see decreased enzymatic production in your exam. You don't need blood tests. You can see it. I think that was the question.
Yeah, I mean, the only way to show a decrease in intestinal or pancreatic enzymes is during an endoscopy.
Okay, that was the question.
Thank you very much. Thank you for your nice presentation and also the first one. I'm Sonia Boyagieva from the University Children's Hospital Skopje, and we are one team here. And this is a good chance to learn something more at this meeting. Thank you for invitation. And with this knowledge from today and tomorrow, we will do something more for our patients. Of course, I would like to ask something about, it's a pediatric gastroenterologist. It is a routine, a guideline maybe, to do to every child with autism, to do endoscopy or colonoscopy. And I saw at your slide that there is a very, maybe the similar symptoms like Crohn's disease, inflammatory bowel disease, are the same also. The therapy is the same, especially doses for biologic, because there is one way how to treat child with biologic therapy, like infliximab, adalimumab, and some others. Thank you very much.
Okay, so thank you very much for that question. So are you a pediatric gastroenterologist?
Pediatric gastroenterologist, but
Okay.
we are learning all the time because we have now
we all
more
are.
and more patients with this disease, and we want to do something more for our
Sure.
patients.
So,
This is my first time to be a part of this kind of multidisciplinary team with neurologists, immunologists, and also gastroenterologists like me.
well, thank you very much for coming, because I know that the
Thank you. We are here with our director of the University Children's Hospital, Professor Dr. Aspasia
who I met
Sofianova.
before. Okay. Okay. So I know that the organizers of this conference,
And thanks to our Ministry of Health and also our society from organizing from Macedonia, and you can see Maria, another Maria, and all the team which we came here from Macedonia. Thank you.
right, and thank you for that. I know that the organizers of the conference, when they organized this conference, this is exactly what they had in mind, that they wanted both parents and also other physicians, other physicians in leadership positions, heads of departments, to come and hear about this, because that's how change occurs. So thank you very much for that. And thanks again for the organizers for doing all the hard work. It was all worth it. So the way you approach these children is the way you approach any other child. Okay, so if there are obvious GI symptoms, right, if there's ongoing diarrhea unexplained, right, we do a colonoscopy. The only difference is that I would do an upper endoscopy also. But the indication for chronic diarrhea, chronic unexplained constipation that's very severe and impacting the child, regurgitation, chronic vomiting, weight loss, these are all things that we would scope a child for anyway. So we do the exact same workup. The only difference, all of my last 20 years, okay, we're all geared. The goal was to make the point that in a child with autism, they can have treatable gastrointestinal inflammation, and the only symptom can be extremes of behavior. So you can have an autistic child who the occupational therapist, the speech therapist, the ABA people say, he's not making any progress. This is a kid who's banging their head. This is a kid who's hitting their chest, hitting their stomach. It's not, they don't put their hand on their abdomen. I don't know why. I've seen appendicitis and ruptured appendixes, and they never put their hand on their abdomen. It's part of their communication disorder. But if you have extremes of behavior that that even amongst the autistic population are extreme, that could be the only gastrointestinal symptom. And that's what we're showing in our data, that that when you treat the GI disease, you treat the behaviors and even the cognition. So we can't say yet that every autistic child should be scoped. The data is not there yet. My suspicion is that that's probably a good idea, but at least in America, we can't do that. Unless you have a clinical indication, you can't perform an endoscopy. So the point over here is that any of those indications, even if it may seem mild, maybe the diarrhea is not 25 times a day. It's once a day, but it's always loose and smelly. So that's how we approach them.